Hi, I'm Stacy, and I'm going to talk about your last exam for Derm. So we're going to go over skin of color, pigmentation, and look at some of the skin and systemic diseases. So I put this into two PowerPoints because I thought there was too many slides. So some of these aren't my slides, and I borrowed them from another tutor a few years ago. So they'll look a little bit different than my usual slides, but let's get started. Okay, so let's look at sweating first off. So we first have hyperhidrosis. So hyper, of course, means a lot. Hydrosis means sweating. So obviously, this is a lot of sweating. So usually sweating is controlled through the sympathetic nervous system, but notice that it's functionally cholinergic instead of, which is different than what you would usually think. So primary is idiopathic. Secondary could be caused from a tumor or medication. I think the most important secondary cause would be Frey's syndrome, which was parasympathetic nervous fibers of the auriculotemporal nerve that is cut after injury. So basically they have this like sweating in the auriculotemporal nerve distribution, which would be sort of behind the ear, and it increases when they eat. So it's kind of crazy. So they'll have this like sweating sensation right after they eat. Usually it's because of a transection of nerve due to like a parotidectomy, or they've had parotiditis, an abscess, somewhere, something in that nerve distribution that has affected or cut that nerve can cause that. So here's some more different secondary hyperhidrosis. Cortical hypothalamic, medullary spinal cord, or axon reflex. So treatment is going to be topicals, is first line with like Quebexa, or second line would be things like Botox, oxybutynin, or glycopyrrolate. Okay, so this is not in the lecture, but I thought it was pretty cool. So I actually had this done to myself, which is kind of weird, but it's called Mirror Dry, and it can stop sweating, and it uses microwave technology. And so basically they just like put a bunch of lidocaine on your into your armpit, and then they put this microwave thing on your arm, and then it completely stops sweating and like odor and all of that. So it's kind of cool. Insurance doesn't cover it, but it's not like crazy expensive, and then you don't sweat anymore. Okay, anhidrosis and hypohidrosis causes can be central diseases like brain tumor, spinal cord injuries, or medications such as anticholinergics or alpha adrenergic blockers. It could be congenital, it could be acquired, or a sweat gland obstruction. So what happens is the skin looks normal, fine, but there's no sweating. And what happens is it results in hyperthermia. So there was this girl in my dance class when I took dance in like middle school and high school. She was older than me, and she had anhidrosis. So she couldn't sweat. So she would be dancing on stage, and then they would have water and fans on the side of the stage. So every time she came off, they were cooling her down, because if not, she would have like hyperthermia. So it's great. Like no one sees you sweat, as far as like appearance wise, and like it's not embarrassing or, whatever. But it's serious and severe, because if you get hot or do any of those things, that we all do, like go outside in the summer or, do any exercise, you're going to overheat because you don't have that ability to sweat. So diagnosis is going to attempt to induce sweating, and then followed by this starch iodine technique. So like you put the starch iodine on there, and it demonstrates no or absent sweating. It doesn't pop up positive. It doesn't produce a color. Treatment is going to be, if they're on medicines that cause this, then stop the meds. Or if there's obstructed sweat glands, exfoliate, and so on. And like, of course, maintain a cool environment. Bromhidrosis is going to be basically brome. I sort of think starts with B, bacterial starts with B. So it's a degradation of the apocrine glands that causes the pneumonia or causes ammonia. And so basically it's like bad smelling sweat. And so it's, typical sweat smells, but it's going to be an exaggeration of the sweat. So there's three types: keratogenic, metabolic, or exogenous. So keratogenic is going to be bacterial degradation of the stratum corneum because of excess sweat. So how do we stop this? Obviously, we do the same things for hyperhidrosis. Metabolic is going to be could be because of like PKU, or it could be because of like maple syrup urine disease with that sweet odor of urine, or exogenous things like I ate too much garlic or asparagus or curry. Treatment: antibacterial soaps, deodorants, surgical removal of the glands, mirror dry like I got, or of course, like stop eating smelly foods. Okay, chromhidrosis is going to be this rare disorder where the sweat is colored, basically. It's kind of unclear. Maybe it's a drug ingestion, and it can stain clothes. Okay, so that's all of sweating. So let's start going into hyperpigmentation. So I'm going to take some of the Campbell lectures and some of the pigmentation lectures and sort of combine them. So skin color is determined based on the activity, not the number of melanocytes. UVA causes an immediate pigmentary darkening, where UVB is kind of delayed reaction. Melanin involves tyrosinase, and which changes into phenomelanin or eumelanin, and it's stimulated by MSH and ACTH on MC1R. Okay, so here's our diffuse hyperpigmentation. So one form is hemochromatosis. So it's autosomal recessive, mutated HFE, and I talked about this in the GI lectures. It's associated with HLA-A3, and hemosiderin is on biopsy, and it pops up positive with Prussian blue stain. So this is just hemosiderin deposits in this picture, and here is like actual hemochromatosis. It causes liver issues because there's going to be that buildup of iron, lethargy, hyperpigmentation. One of the parts of the trilogy is going to be Braun diabetes and liver problems. It can also cause arthralgias and impotence, hypogonadism. If you think about all of this, think iron is depositing in all of these places, and it's almost like it deposits and gets stuck. That's kind of what I think. So it deposits. So it's in the pancreas. We're not able to produce insulin, causes diabetes. We're in the joint spaces. It's accumulating. Okay, it's going to make my fingers hurt. Okay, it's depositing in the reproductive organs, so it makes them not work. So that's how you can kind of think about why does this make it happen. So remember that triad of cirrhosis, diabetes, and hyperpigmentation. Here is the form, or here's what it is in first aid. So I'll let you look at that. So Addisons disease, I'll go right back really quick. So HFE, so the HFE stands for hemochromatosis, and then FE is iron. So that's how you can remember it. Okay, Addison's disease is due to primary adrenal insufficiency, which ACTH, which increases MSH. So our symptoms are going to be fatigue, hypotension, hyponatremia, hyperkalemia, metabolic acidosis, anorexia, weight loss, and weakness. And there's going to be hyperpigmentation. So it doesn't occur with secondary or tertiary adrenal insufficiency, but only primary Addison's disease. Acute is going to be hemorrhage, which is called Waterhouse-Friderichsen disease. Chronic would be like autoimmune or tuberculosis. So here is our adrenal insufficiency with primary Addison's disease. So remember, it's that adrenal atrophy or destruction. So primary pigmentation both start with a P, so secondary doesn't. Localized hyperpigmentation, melasma or cholasma. It's associated with pregnancy where there's a melanin deposition. It can also commonly occur with use of OCPs. So places that the sun gets to causes hyperpigmentation, so they get that glowing skin. So basically, how do I prevent against this? Sunscreen. Ochronosis is going to be hyperpigmented plaques, and it's usually associated with excessive hydrochloroquine use or hydroquinone use. I'm sorry. So treatment is going to be stopping the medication, and it'll slowly resolve. Acanthosis nigrans is going to be associated with diabetes and endocrine disorders and malignancy. Know that it's associated with insulin resistance and diabetes type 2. The symptoms are going to be these hyperpigmented plaques, usually located in the neck or the axilla, as shown in the pictures. Okay, erythema ab ignae is going to be a chronic exposure to heat or infrared radiation. It's going to be reticular, sort of looks sort of lacy-like. It's erythematid pigmented dermatosis. So basically, how do you get rid of it? Remove the heat source. So I'm really bad about it. And like, I've got a heating pad like right now. I love to like lay on heating pads, but my skin's gonna like look like that if I keep it up. Okay, so a way to quiz yourself is that you could, the way that these slides are, it shows the picture first. So you can look at the picture and think, okay, what would this diagnosis be? So this would be Puig-Jager syndrome. It's autosomal dominant STK11 gene. So it's serine threonine kinase 11. It's associated with a colon malignancy, usually your breast, stomach, or small bowel or pancreas. It has these mucocutaneous lentigines, which are liver spots with an intestinal hematoma polyps, anyways, that are non-cancerous. These are hard to say. So make sure that you know if you get these like hyperpigmented mouth lesions, that you know that it's associated with breast or GI cancers. Cafe au lait macules are going to be associated with 3 different things, NF1, okay, the first 2 are both NF1, but NF1 or McCune-Albright syndrome. So NF1 is going to be greater than 6 cafe au lait macules, neurofibromas, and axillary inguinal freckling, and leash nodules, which are again on the iris. And those are autosomal dominant. McCune-Albright syndrome are going to be due to a mutated mosaic G protein signaling. It has unilateral cafe au lait spots. So if you're looking at this and these cafe au lait spots are on one side of the body versus bilateral. If it's bilateral, it's NF1. If it's one side, it's McCune-Albright. It has these like jagged borders, and then they have polycystic fibrosis dysplasia and precocious puberty. So I would like make sure that is one I knew. I'm pretty sure I remember it popping up. So unilateral cafe au lait with jagged borders, polycystic fibrous dysplasia, and precocious puberty. So the bone is going to be replaced by collagen and fibroblast, and then they're going to have an endocrine disorder as well, like puberty that pops up too soon. Okay, so here are some of the pustular neonatal disorders. I would know the difference between the first 2, transient neonatal pustular melanosis and erythema toxicum neonatorum. So transient neonatal pustular melanosis. So neonatal pops up first. So they both have sort of a neonatal word in them, but neonatal is the second word in the two, between the two. So transient neonatal versus erythema toxicum neonatorum. So the one that has neonatal first is present at birth. That's what I'm trying to get you to remember. So that one's present at birth. It can be anywhere on the body. It's these like superficial fragile pustules, and there's going to be neutrophils on right stain. So know that transient neonatal pustular melanosis, present at birth, neutrophils. Erythema toxicum neonatorum, it looks very similar. Now, in this picture, it looks very erythematous, but in some of the pictures, it looked basically the same as this. So not going off picture, it's not present at birth. It takes 2 to 4 days to present, and then it resolves in a few weeks. But there are eosinophils on right stain. So present at birth is transient neonatal pustular melanosis. Erythema toxicum neonatorum takes 2 to 4 days. The first one has neutrophils on right stain, and the second one has eosinophils. The other pustular diagnosis would be acropustulosis of infancy, and it's only on the hands and feet, and it starts with scabies. Okay, so that was our hyperpigmentation. Here's hypopigmentation. So diffuse hypopigmentation is our first one, occult albinism. It has decreased tyrosine activity or transport. It has a normal number of melanocytes, but decreased melanin production. That is super important to know against our next one, which will be vitiligo. So albinism has normal melanocyte number, but decreased melanin production, versus the other one that is not going to have melanocytes. So OCA1A, so occult albinism A1A, is the most severe, and often these patients are also blind. Okay, localized vitiligo is going to be a loss of the epidermal melanocytes. So make sure that you know the difference between vitiligo and albinism. So albinism, we have normal number of melanocytes, but decreased melanin production. Vitiligo is going to be a loss of epidermal melanocytes. And so you can see in this histology side that like right here, we've got melanin and like in melanocytes, and here we don't. We don't see any like little, these look like little black dots to me. There's no little black dots right here. So that's vitiligo. So you have patchy areas of depigmentation. Wallenberg syndrome is going to be a autosomal recessive mutation at chromosome 11. They have piebald depigmentation, so basically it's that like white forelock. They have pale skin, heterochromia, a broad nasal root, so you can see that these noses are pretty wide. They have lateral displacement of the intercanthi, so they're going to have wide spaced eyes, and then they're going to have congenital deafness as well. And you can see these features in all of these people right here. Idiopathic Goutet hypomelanosis is going to be commonly acquired. It affects women more than men, usually after age 40. It's these small little hypopigmented macules on the shins and forearms, usually not on the trunk or face. The location is usually because of sun exposure, but also other things can, cryotherapy, phenol, carbon dioxide, laser, and calcium inhibitors might help. It's kind of funny because like cryotherapy actually also causes hypopigmentation, so I'd be a little careful with that one. But here's this. Koyagi-Harada syndrome is going to be a multi-system disorder, usually consisting with uveitis, aseptic meningitis, vitiligo, and poliosis. It's going to be affects all races, usually females more than males, even though there's a male in this picture. It's an autoimmune disorder. There's 4 phases. It's going to have this prodromal phase, which they have malaise, fever, headache, nausea, vomiting, and tinnitus. And then usually they recover from this, and then they get this like anterior or posterior uveitis. And then they have this convalescent phase, which begins three weeks to months after the uveitis appears, and they get this alopecia, vitiligo, and poliosis, and then they get these recurrent attacks of uveitis. So they'll have like decreased acuity of their vision, cataracts, or glaucoma. Vatt-Kolanagi-Harada syndrome. Okay, let's look at mixed pigmentation disorders. So we have hyperpigmentation and hypopigmentation combined. It's sort of based on 2 like skin tone. So first is going to be radiation therapy. It's acute. It has a hyperpigmentation, but chronically it can result in telectactasias. Treatment is going to be topical steroids. Tinea versicolor is going to be caused by melanacia. It's degradation of lipids producing these acids which damage melanocytes. So there's going to be hyper or hypopigmented areas, commonly seen after a suntan. So after somebody goes in the sun, then sort of activated, and you or at least you start really seeing this. On diagnosis, you see these like spaghetti and meatballs on KOH, and the treatment is going to be like blue shampoo, that psyllium sulfide shampoo, or like azoles. Discoid lupus, the ANA is going to be negative. In discoid, it's positive, remember, in systemic lupus. It's photosensitive, discrete erythematous indurated plaques, and scarring. It's discoid, not always, but sometimes looks, circular. Treatment's going to be sunscreen and avoid certain medications, smoking cessation, vitamin D, and topical steroids. Phototoxic reactions are going to be drug induced. It causes these exaggerated sunburn. So basically, it's like the sun fries, like antibiotic or drugs cause this. So great example, doxycycline. So if you can give your patient another antibiotic, if they're going out into like, on the beach or something, or they're going to be out in the sun, that would be better because it causes this exaggerated sunburn, and you don't want to cause your patient, sun damage or, potential reasons to get sunburn. Okay, I think this is like the weirdest one and exciting. So phytophotodermatitis is going to be caused by coumarins and celery, parsnips, parsley, lemons, and limes. So they get this like erythema, edema, and bulla, and like these weird linear, bizarre patterns. And basically you just stop exposure to it and offer sunscreen. So phytophotodermatitis. So if you see this, think it's like a vegetable or citrus fruit. Hepatic acute intermittent porphyria. So remember back to MFM1. We have autosomal dominant mutation in porphobilin deaminase and uroporphyrin synthase. So diagnosis are going to be urine porphobilin, PBGs. Symptoms are going to be the 5 Ps. So this is the way I remember this one, because there's all of these like porphyrias, and I think that they're sometimes hard to remember. Really, the top 2 are the most important to remember. But the one that has porphyria in the name, acute, and it says acute. Okay, it starts with acute. That starts with an A. Abdomen also starts with an A. So then I think, okay, the one that has the abdomen starts with an A and acute starts with an A, and then I can get the rest. So it has the 5 P's: painful abdomen, port wine urine, polyneuropathy, psych issues, and it's precipitated by drugs. Treatment's going to be glucose and hematin because it inhibits ALAS. So if you hear like weird skin disease and you have like a skin disease with a really painful abdomen, then think it's this one. Okay, Porphyria cutanea is going to be autosomal dominant, mutated UROD, and it's associated with Hep C. So this one, unlike our friend over here, acute AIP, abdomen, this one has a C in it, so it's associated with Hep C, cutaneous C, Hep C. Symptoms are going to be blistering, scarring, photosensitivity, and it has that tea-colored urine. So they both have dark urine, but this one has more of the skin manifestations, where the other one had more of like psych issues and abdominal pain. Arsenic poisoning acutely has flushing facial edema. Over time, they have these like bronze hyperpigmentation and these me lines in the nails. And then they have an increased risk of cancer. Drug-induced hyperpigmentation, most common ones are going to be like chloroquines, and they get that blue-black pigmentation, or amiodarone, and they get this like slate gray hyperpigmentation that you can see in the guy at the bottom. Acanthosis nigrans is going to be GF stimulation of keratinocytes with dermal fibroblast. This is associated again with insulin resistance, diabetes type 2, and obesity. And it also can be GI malignancy if it's PO or palmar lesions. They've got these hyperpigmented, thickened, velvety patches. Sweet syndrome and febrile neutrophilic dermatitis is going to be increased CSF. It's going to inhibit apoptosis, and it's associated with heme malignancies like myeloid leukemia. They get multi-painful erythematous plaques and fever. So a lot of these syndromes, it might be like that they have a rash that's itchy, or they have a rash that's non-painful, but this one's different because they have a painful rash and a fever. Treatment's going to be systemic steroids, and then of course look for what's going on, like look for a malignancy. Make sure that you rule this out. I mean, it could be strep pneumo, it could be pregnancy, it could be drug, but like make sure that you rule out a malignancy. Okay, so here's sweet syndrome. It's usually preceded by upper respiratory tract infection. It can be associated with bowel disease, pregnancy, but they have these like fever and tender lesions. And they get these like diffuse infiltration of mature neutrophils, and know that it's associated with GCSF. Okay, now we have these eye lesions. What could this be? Amyloidosis skin, it's associated with multiple myeloma. It's non-palpable purpura, and it's also associated with smooth, waxy skin. So now we have these lesions, which are erythema gratum or Gamel disease. So they have this cross-reactivity, absence to tumor, and it's associated with lung, esophagus, or breast cancer. As well as some other diseases as well. So you have these pruritic, so itchy, wavy erythematous bands arranged in parallel rings. So don't look at this wood grain looking pattern and think, oh, it's just a fungus. So, because it sort of looks fungal if I first look at this, but these are not fungal, super itchy, and it has that wood grain pattern. And if we biopsy, it's going to have a sonophilia. Seborrheic keratosis is going to be aggravating or activating mutated FGFR3 gene. So seborrheic keratosis is going to be this greasy paste stuck on. So seborrheic stuck. And lesser Trele sign is when you get a bunch of SKs that all appear at once. It is an indication of a possible GI malignancy. Don't confuse it with seborrheic dermatitis. SK is greasy stuck, has a K, SK, stuck on, where SD is cradle cap. So that's how you remember these two. And this is what it looks like on histology. I would make sure that I knew that, what it looks like on histology, and know that if a bunch of SKs appear, that's lesser Trele sign, possible GI malignancy, mutation FGFR3. Okay, so now we see this lesion. We have some telectasias. We have this. It's like in a, or it's contained. What could this be? It's an epidermal inclusion or sebaceous cyst. It's mobile, firm, dome-shaped, flesh-colored with a central pore. And here's the central pore. Okay, they don't usually have telectasias. This one just did, but it's foul-smelling, cheesy, keratinous material. Gardner syndrome are going to be multiple of these plus FAP and osteomas. So skin disorder, osteomas, and FAP, that's Gardner syndrome. So it involves skin, skin, bones, GI, Gardner. Mutor syndrome. I feel like this one was important. I feel like Gardner syndrome is really important too, by the way. So make sure that you know the association, you know the three things that go with that: FAP, osteoma, multi-epidermal cyst. Mutor is going to be autosomal dominant mutated MSH2 and MLH1, which are mismatched repair genes. Symptoms are going to be sebaceous tumors and papules. So you might see like, and it's associated with internal malignancy. So you see these, a lot of these in these papules, and you see sebaceous tumors and think, okay, mismatched repair, MSH2, MLH1, and internal malignancy. Cowden syndrome are going to be multiple hematomas and neoplasms. It has a mutated P10 tumor suppression, breast, endometrial, follicular, thyroid cancer. Symptoms are going to be hamartomas, polyps, tricholimoma. I'm terrible at this. Acral keratosis and pyofibromas. So you can see these located on the face. Tricholeomas. And know that it's associated with cancer as well. So Cowden syndrome, multiple hamartomas and neoplasms. Here's Jager syndrome, again, just putting it with these other malignant syndromes. So autosomal dominant mutated STK11 associated with GI cancer and non-GI tumors as well. So you get these mucocutaneous pigmentations, as well as maybe a hamartomatous polyps of the GI tract, which can result in obstruction. Gorlin nevoid basal cell carcinoma syndrome are going to be a mutation of the patch associated with BCCs, medulloblastoma, and jaw cyst. So basal cells, mutated patch, medulloblastoma, and jaw cyst. Okay, skin lesions associated with GI disorders. We've talked about some, but here's some more. Pyoderma gangrenosum is going to be associated with rheumatoid arthritis, IBD, myeloma, leukemia. Symptoms are going to be a neutrophilic dermatosis with painful ulcers and that dusky violet border. So you can see like right here, we see this like violety border. But like on darker skin, it doesn't look violet. But you can still see that there's an ulcer in both of these, and they are very painful. So this person was getting a skin graft, and the graft is not, or they've got this pyoderma gangrenosum at where they removed the graft. Okay. Now, necrodermatitis enteropathica is going to be a zinc deficiency. Zinc deficiency associated with diarrhea, periorificial dermatitis, and alopecia. I think that this is pretty important to know. So if you see a picture like this of a baby, there's not too many babies in this except for the pustule diagnosis. So if you see this baby with this like perioral dermatitis and then they have alopecia and diarrhea, know that it's due to a zinc deficiency. Now we have an adult. Necrolytic migratory erythema. It's associated with the gluconoma. They've got these scaly annular migrating erythematous papulous patches or plaques with bullae and erosions. So this is because of a tumor secreting glucagon. Usually of the pancreas of the alpha cells. So know that glucagonomas presents with dermatitis, diabetes, DVTs, declining weight, and depression. So all D's. Treatment's going to be octreotide and then surgery to move the tumor. Osler-Weber-Randall syndrome is hereditary hemorrhagic telangiectasias. It's associated with these multiple telangiectasias and AVMs, as well as GI, nasal lesions, epistasis, and hemorrhages. And I think that this one's like really important. It's a really common thing to be tested on. So know that Osler-Weber-Randall is basically telangiectasias and other vascular malformations in multiple areas. So I know that this is a ton of things to remember. So basically you're just going to have to like flashcard all of these, I really think, to remember them, and make sure if you look at a picture, you can associate it and know all of the things that go with these syndromes. It's not fun, but I think it's the way you're going to have to know it. Spider angiomas are going to be associated with liver disease or thyroid toxicosis and estrogen therapy. They've got these blanching caps radiating outwards. Hep C associated manifestations are going to be leukocytoclastic vasculitis, so palpable purpura, and petechiae. So no, Hep C is associated with palpable purpura. Lichen planus is going to be associated with Hep B and PBC. Porphyria tarda has the photosensitivity and blisters. Remember I said C, just like Porphyria cutanea. So they both have that C. And then necrolytic acral erythema is also a Hep C manifestation. Erythema nodosum, paniculitis. It's associated with TB, leprosy, sarcoidosis, IBD, and neoplasms. It's these tender erythematous plaques of the lower extremity. They have these arthralgias and flu-like symptoms. Sarcoid has really an unknown etiology, but most common in African American women. It has non-caseating granulomas, unlike like TB that's caseating. They have these Schwammen and asteroid bodies, and symptoms are going to be hyaloid lymphadenopathy and hypercalcemia with an increased ACE. and also like increased calcium. Oh, I guess I did say that. Oh, well. And so here we can see these non-caseating. We can see this hilar predominance in the chest x-ray and CT scan. Tuberous sclerosis is a autosomal dominant mutation of TSC1 or TSC2. It has these hypopigmented macules, ash leaf patches, chagrin patches, angiofibroma, adenoma, subungual or periungual fibromas. And the way to like remember this is hamartomas. So if you take each letter, H, hamartoma, A, angiofibroma, M, mitral regurg, A, ash leaf, R, rhabdomyoma, TS is tuberous sclerosis, O is autosomal dominant, and the M stands for like intellectual disability. M, and we already said that. A is going to be angiomyolipomas, and then S, seizures and chagrin patches. And so here's some pictures of this. So neurofibroma. So I know the difference between these two. Neurofibromas also have nodules, but these are more like buttonhole size nodules. So the lesion compresses and goes inwards when compressed and is associated NF2 with benign peripheral nerve sheath tumors. NF1 is autosomal dominant, shredded carrot appearance, plexiform lesions, and has sort of this like bag of worms appearance. And they have leash nodules. This is what's shown here. And those cafe OLAs greater than 6. NF2 has a cranial nerve 8 nerve schwannoma and multiple meningiomas and epidemiomas. And here we have our first aid. Schurg-Weber syndrome is going to be activating mutation of QNAQ. It's got vascular ectasia, port wine stain. They've got venous angiomas, and then intellectual disability, seizures, and glaucoma. So you can remember it by Sturge, S, sporadic, and port wine stain, tram tract calcifications in the opposite gyri, unilateral intellectual disability, glaucoma, and G in a Hugh gene and epilepsy. Ataxia telangiectasia is going to be a mutation of the ATM. It's a defective DNA repair. There's immunodeficiency, ataxia, telangiectasias, and death. So congenital disorders. Leopard syndrome is going to be a mutation of the TPN11 gene. So you have lectines, EKG conduction abnormalities, ocular hyperteloturism, pulmonary stenosis, abnormal genitalia, retardation of growth, sensorineural deafness. And leopard syndrome is not because they look like a leopard. It's because if you take that, like the L stands for lectinase, E stands for EKG conduction, O, and so on and so forth. Carney complex, Lamb name syndrome are a mutation of the PRKAR1A. Lamb, again, it's because of these. So we have lectinase, atrial myxomas. We have that, freckling, multicutaneous, mucocutaneous myxomas, and the blue nevi. So I would know those are Carney complex. Name, nevi, atrial myxoma, endocrine neoplasia. Okay, and autoimmune disorders. Systemic lupus erythematosus are going to be that malar butterfly rash. It has a raised scar-like atrophic red plaques and scarring alopecia and with a photosensitivity. So you can remember SLE with rash or pain, rash, arthritis, keratosis, hematologic disorders like cytopenias, oral nasopharyngeal ulcers, renal disease, photosensitivity, ANA positive, immunologic disorders like anti-double-stranded DNA, anti-smooth, antiphospholipid, and then neurogenic disorders like seizures, psychosis, and that's how you can remember these. Common causes of death are going to be renal disease, infections, and cardiovascular disease. Dermatomyositis is going to be a complement deposition of MAC and CD4 T cell infiltrations around the blood vessels. So you're going to have a perivascular location of inflammation infiltrates. So you have the symptoms of heliotrope, and gratum papules are going to be these like scaly patches on the knuckles, elbows, knees. Visceral cancers, cardiomyopathies, arrhythmias, teletictasias, polycleoderma, and calcinosis cutis, which is shown right here. So I think of like really a lot of times they'll show the upper eyelids or the gratum papules. And so know that that's associated with dermatomyositis, which is very similar. They don't have it, but it's very very similar to the one without a derm manifestation that I currently cannot think of off the top of my head, but know that this one is associated with the like purpley eyelids and gratum papules. Does it say? Oh, yeah, it's clinically similar to polymyositis, but it has that rash. That's what I was trying to think of. Scleroderma is going to be like that dusky, hypopigmented, indurated plaques with a violet border, as you can kind of see here. I don't think it really looks violent, but anyways. Crest syndrome is going to be calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and Teletictasias. Endocrine disorders, and then we're almost done with these lectures. Pretibial myxedema is going to be associated with Graves' and Hashimoto's disease, and it has that deposition of GAGs, our hydrolonic acid. It's non-pitting, unlike some of our like cardiac edema, but they have these bilateral, scaly, firm, shiny nodules as well. Necrobiosis, lipicodia, diabeticorium. If you like just look at that, lipid and diabetic is in the name. It's associated with like a neuropathy and a microvascular changes in diabetics. Well circumcised and has that waxy center. There's a granulomatous infiltration as well. The deligo, again, we've already went over this. Xanthoma is going to be severe chylomicronemia and triglyceridemia. It's that yellow-orange appearance, and it's usually familial because of familial dysbeta lipoproteinemia or familial hypercholesterolemia. It's that pink, yellow. There's palmar. It can located at the eyes, multiple locations. AIDS findings, viral infections, fungal infections, bacterial infections, know that they've got multiple infections, opportunistic diseases. Bacillary angiomatosis is going to be a proliferation of Bartonella. And then know that Kaposi syndrome is HHV8 or Kaposi. So here's the bacillary angiomatosis. I think that I had to like know this versus this between these two. So make sure that you know that the bacillary angiomatosis is associated with Bartonella. And to get rid of it, you treat the Bartonella, where Kaposi is that HHV8. But it has that lymphocytic infiltrate. Oh yeah, and this, okay. This has a neutrophilic infiltrate, and it also has this like buttoning or like sort of like it goes inwards. And it's a benign lesion where Kaposi is a malignancy. So bacillary, neutrophils, Kaposi, lymphocytes, which makes sense. One's a bacteria and one's a virus. Okay, last slide. Seborrheic keratosis again, FGFR3, lesser sign is a bunch of these, and it's associated with a GI malignancy, and they have that stuck on lesion, stuck to skin, versus the seborrheic dermatitis has a D, so cradle cap. All right. I will finish this and then get to the next one so you guys can like study for your tests.